mainly have three compartment: anterior cranial fossa, middle, and posterior. And you have here the main location of meningioma in this skull base. I cannot treat all these specific location. I will try to address a couple of them: tuberculum sele, olfactory growth, sphenoid wing here, foramen magnum, and the cerebellopontine angle. As general aspect, and that's a slide I adapted a bit from our American colleague Mike McDermott from the UCLA, I think that's a typical case for radiotherapy, at least in my comprehension. That's a large invasive tumor which is touching wrist structures, optic nerves, or optic chiasm. And that's a typical case for radiosurgery. You have a small to medium-sized target. I don't believe in numbers, but I think 3 centimeter for single fraction or 3.5, depending on the anatomy of the region, is a good limit. And you have to have a distance of security 2 to 3 millimeters independently of the radiosurgical technique. And I think that's an ideal target for single fraction. Now, we know that for meningiomas, at least for the grade 1 tumors, we have a window of therapeutic doses which ranges between 12 grays to 16 or 17 grays in most of the series. Up to 10 years, I think we have around 90% tumor control. We have a decrease in size of half of these tumors, and the rest remain stable. I think we have also a selection bias for radiosurgical techniques, and this involves mainly lesions which are unfavorable for surgery. Skull base, when you have a sinus involvement or other location. We have a low complication rate, which is mostly transient, less than 10%, and I will come back to this. That's also, I think, for radiosurgery and for radiotherapy as main indications. I think we can do it at first-line treatment as an alternative to open surgery, or if it's the only possible treatment for the patient. If you have a recurrence after previous surgery, or if you want to do a complement to surgery, either adjuvant radiotherapy or in planned combined approaches with single fraction radiosurgery. Another important aspect for meningiomas of the skull base is that if you compare the total resection rate, it's depending a lot on the site. A convexity meningioma, you can usually take it easily out, especially if it's not involving a vessel or something. And you can see here in red the total resection rates in skull base meningioma. So in most cases, you would need a complementary treatment if you have an invasive tumor. The problem is you have cranial nerves, you have vascular structures, and you have the brainstem. So you usually have to leave a remnant in place. Again, as a general aspect, that's a paper which is quite old from the Mayo Clinic, Bruce Pollock, and I think that's important. Radiosurgery and complete surgical resections are considered equivalent in small to medium-sized asymptomatic tumors. No symptomatic mass effect in these patients. A small slide on histology. I think the WHO grade, it's important. The control rate at 5 years is definitely not the same in benign, atypical, and malignant meningiomas, and that's again a paper from the Mayo group. Now, an overall aspect on single fraction radiosurgery for skull base meningiomas. This is the European study, almost 6,000 meningiomas, mean follow-up 5 years. You can see the huge number of cases, for example, cavernous sinus, 1,200 cases, olfactory growth, 53, middle cranial fossa, so huge number of cases. And this is a slide from Antonio Santa Croce from Düsseldorf, who had actually went in each European center and collected these cases. This is mostly unpublished data. Skull-based meningioma, as you can see at 10 years, local progression-free survival, 90%. And this is actually, I think, a good number, and it's reflecting well the reality in most of the center. That's a recent paper. I cannot quote everyone, but I think that's an important paper which just showed up in neurosurgery from Jason Xian, Charlotte Zwitten Cohen in Bar, who is in Tel Aviv. 135 patients. The important thing, they had long-term follow-up. This is benign meningiomas, grade 1. Median marginal dose as a prognostic factor, 15 grays in single fraction. And you can see the tumor control rate, 95% at 10 years. 70% at 15 years. I would be very cautious with this control rate at 15 years because I would say the crude treatment planning we were doing 25 years back are not comparable to what we are doing today. So I think this number should be a little cautiously interpreted. At 10 years, you can see a review of all series, roughly around 90% tumor control. Again, the same author, he's doing another paper with another group. He's analyzing the impact of the dose, and you can see for more than 14 grays, at 10 years, you are around 85% tumor control in single fraction. And again, Jason Xian, that's a guy who is very active and very correct in his publication. He's reporting large skull-based meningiomas. I think two aspects are important. One is the volume. So if you treat large volumes, 14 cubic centimeters seem to be a factor, and also no previous surgical resection as an additional factor. That's a study which is from 2012. It's comparing all the techniques together. I won't insist a lot, but you can see here the Kaplan-Meier curves, which show no statistically significant difference between single fraction and hypofractionated or fractionated radiotherapy. I think these patients have different volumes, so it's difficult to compare one technique with the other, but the overall message, I think that's correct. The progression-free survival rate is more or less the same on a long-term basis. A couple of challenging cases in single fraction, just as an example, that's a cavernous sinus meningioma close to the optic pathways, an anterior clinoid meningioma, again, very close to the optic pathway, quite impressive case of an olfactory groove with the two optic nerves surrounding the tumor, and a couple of skull-based locations close to the brainstem where we prescribe mainly 12 grays at the margin. I will briefly address a couple of locations. Cavernous sinus, I think that's important because at the neurosurgical knowledge we have now, we don't resect tumors in the cavernous sinus. We had some pioneering series 20 years back, 30 years back, but now we stopped doing this. One of the limiting factors is the optic nerve. So tumors which are close to the optic nerve and the optic chiasma need a distance of 2 to 3 millimeters to be able to do a single fraction. We also do a combined treatment in some of the cases I will show you. And I think it's important also to know that the content of the cavernous sinus, all the oculomotor nerve, the fifth nerve, are extremely resistant to radiation. So we, at least in my experience, I never seen a complication after treating a cavernous sinus meningioma in single fraction. We had a nice fellow coming from Lille, France, who trained in our center, and we were discussing together what we could do to bring something new, and we took the cavernous sinus meningioma, so I was happy to share this data with you. We just submitted our paper on Monday, this Monday. We reviewed almost 3,000 patients, most of them in single fraction radiosurgery, gamma knife for linear accelerators, and fractionated radiotherapy. And I think mostly these two cohorts differ in two aspects. One is the tumor volume. You can see here we are roughly around 7 cubic centimeters for single fraction. We are around 12 cubic centimeters for fractionated radiotherapy. A second aspect is the prescribed dose. You can see here we are around 14 grays as a median dose in single fraction, and in fractionated, of course, we give higher doses because we have larger volumes and the technique is different, so it's quite normal. That's the tumor control. It was not statistically significant between the single fraction and the radiotherapy group at 5 years and 10 years. We had more regression after single fraction treatment with gamma knife surgery, but I think, again, the volumes are not the same. We cannot compare these things in this way. But the important message is that 5 years, we didn't have any difference in local control. Oculomotricity improvement in up to half of the cases. So this is very important. Trigeminal pain, again, improved in half of the cases. Visual acuity improvement, 20% of the cases. So in all data published up to 2016. Adverse radiation effects, very low, 4 to 9%. If you compare this to what we find in surgical series, in the best hands, de novo deficits after surgeries, you can see here up to 30% in Delphinis series in Rome, so quite an impressive difference, I would say. That's a case we treated in Lausanne with upfront radiosurgery. You can see the planning, the optic nerve just passing nearby. 3 years after the tumor shrank, patient was clinically fine, no optic problem. That's a case where we did a combined approach. You can see the image before surgery. So we took out the infratemporal part. We left the cavernous sinus meningioma in place. You can see the results 3 years after radiosurgery with shrinkage of the tumor. Again, the patient was fine, no deficits, no clinical problem. That's an extreme case, a huge cavernous sinus meningioma, cavernoclinoid. We left, again, the cavernous sinus meningioma in place. And additionally, we inserted, and we are doing this frequently, a fat graft. This is called the chiasmopexy. Actually, this is considered a spacer, and it's allowing us to have a buffer between the optic pathways and the tumor, which allows to give a safe dose to the tumor while protecting the optics. Again, you can see the 3 years result after gamma knife surgery, so tumor shrank and the patient had a normal visual acuity, no oculomotricity problems. So I think the most important in these tumors is that we have a chance to improve cranial neuropathies up to 50%, and that's very important. We have no risk of pituitary insufficiency because the stalk, which is supposed to receive less than 15 grays, it's far away. And if we do a combined approach, we don't wait to see tumor progression. So we are doing it, we do radiosurgery 2 to 3 months after surgery. Petroclival, I will just say a couple of words. Again, it's difficult to address all the location, but just to have an idea, they have a more variable clinical presentation. Usually they are compressing vital structures. You have an image here with brainstem compression. We have the brainstem as a limiting factor. So usually if you have a tumor compressing the brainstem, we are prescribing 12 grays at the margin if we have a contact with the brainstem. We have new functional challenges we discussed yesterday. Dr. Chernov presented this nicely. I won't insist on it. What is the problem with these tumors? At least in the petroclival location, that's a nice paper from Belgium. We have almost 80% radiological tumor growth. So these tumors are growing anyway, and 60% they will further give a functional deterioration of the patient. And again, that's a paper from Douglas Kondziolka and the Pittsburgh group, 2010, showing that in small to medium-sized tumors less than 8 cc, with single fraction in petroclival, you arrive at a high control rate on a long-term basis. This is a case we treated in single fraction. Just to have an example, we do a multimodal imaging always, as Dr. Padik showed yesterday, to be able to well delineate our target. And that's an extreme case where we applied a combined strategy. You can see 11 cubic centimeters preoperatively. Patient had long tract clinical signs. We operated this patient and we left this small tumor 5 cubic centimeters and 2 years after gamma knife, small decrease in volume. The patient was again fine. So I think this, I won't quote all this slide, but I think Volker Seifert, who was considered one of the top neurosurgeons in the world, it appeared in the top 10 neurosurgeon last year, was stating that by combining advanced microsurgical technique with, I would say, either radiosurgery or radiotherapy, we can achieve preservation of the quality of life in these patients. And these were tumors which were considered inoperable just 50 years back. So we have a lot of advancement in this field. Just 2 slides on paraoptic meningioma. That's a tumor where we were quite brave. We had a small contact with the optic apparatus. We treated it in single fraction. We pushed a bit the upper dose received by the optic pathways, which was around 11.5. 3 years after radiosurgery, tumor shrank, patient was fine. We didn't have, on this short-term basis, any clinical or radiation-induced neuropathy. That's a case we treated in fractionation with the new gamma knife icon, 24 grays at 50%. The tumor was invading the optic nerve. I don't have follow-up for this patient. We just treated it 3 months back. And as a main strategy, if we have a little space between the optic pathways and the tumors, we used to do single fraction. If we have larger tumor, either invading the nerve or completely invading the area, either we do a combined approach, either we do fractionation, depending on the patient status, visual status at baseline, and the size of the tumor and the invaded surrounding structure. Main limitations we have with the radiosurgery, at least I think, are volumes, are location, atypical and malignant and infiltrative type. For me, it's radiotherapy indication, so we won't treat this patient in single fraction or with radiosurgery. Marginal doses are quite safe and quite low, between 12 to 17. We have up to 15 years in recent studies, and I think tumor control up to 5 to 10 years, it's around 90%. Clinical improvement between 13 to 45% and low rate of permanent deficits, and I think that's important, 2 to 9%. Now, I will try to do a brave act and speak a little bit more about radiotherapy. I think in most of the studies, 50 to 55 grays and 30 to 33 fractions are common fractionation schemes. 10 to 20 years local rate controls ranging around 80%. Tumor shrinkage, again, a lower rate as compared to single fraction, but again, I think this is related also to the volumes and the different radiobiological effect. And I think with less than 50 grays, at least in the published data, there is a high risk of recurrence. Clinical improvement or stabilization ranges roughly in all series I've seen between 69 to 100%. That's a recent paper which is quite nice, who was just published in 2016 from Caroline Chang from MD Anderson Group, comparing radiation for skull-based meningiomas. You can see here the single fraction radiosurgery, 89 to 96% of local control at 5 years. And if you go to the radiotherapy, no matter the technique, you can see the local control again is going between 93 to 97%. So the control rates at 5 years are similar. I think the histological grade, it's important when we choose the technique. Of course, grade 1 meningiomas, small to medium size, are fit to single fraction. If you have an invasive tumor, recurrent postoperative meningiomas, and of course, if you have higher volumes, you would have more need of radiotherapy and more recurrence rate. Neurological improvement, 14 to 44%. Late toxicity from cranial nerves, pituitary function, or neurocognitive function, which is very low, less than 5%. If you go to grade 2 or grade 3, I think postoperative radiotherapy is very important. You have 7 times more risk of recurrence on the short-term basis, so the doses are more again, and it's an escalation, and that's important. So I think postoperative radiotherapy improves progression-free survival after subtotal resection in invasive tumors and if you have a postoperative tumor volumes. We wouldn't go for single fraction if you have a large volume, and that I think is very important. Upfront radiotherapy, it's the definitive treatment if you have an unresectable tumor or tumors too large for radiosurgery. And you have a paper from the ERTC trial, which is a little bit showing a small scheme how to deal with these patients. Overall risk of complication with radiotherapy between 0 to 20%, depends a little bit on the technique, but still I think the risk as compared to the benefit is very low. And that's a paper from Douglas Kondziolka and Christian Ton from Germany, Kondziolka from Pittsburgh, showing how we should deal with skull-based meningiomas depending on the histological grade. And I think you can see this paper published in 2012. It's a very nice paper. I think it summarizes well what has been done in single fraction and in fractionated radiotherapy up to date. So, and that's one of my final slides, when to treat and want to treat. I think large symptomatic lesions are surgically feasible. Total resection when possible. We avoid, at least in our setting, what I call heroic surgery. We stopped consider as the Superman of radiosurgery. So if we have a sinus involvement or skull base location, we are trying to pay attention to risk structures. If we have a residual tumor, we do either adjuvant radiotherapy or single fraction radiosurgery. We do a lot of combined approaches, as I showed you, with planned subtotal resection and single fraction radiosurgery. And for small symptomatic, we perform surgery or radiosurgery depending on the patient choice. And asymptomatic, we usually do observation treatment. So, and that's my final slide, patient management has definitely evolved. As I was telling you, we cannot consider the series published 20 years back with the crude dosimetries with what we are doing nowadays. Microsurgery and stereotactic radiosurgery and radiotherapy may be the best treatment option in this patient. And I think even better clinical outcomes can be expected. Thank you for your attention.